So, dear Dr. Neena, it will be all the faculty members and the students who are present today for this webinar. Very good afternoon to all. Cardiovascular diseases are leading cause of pregnancy-related mortality in United States and has gradually increased over time and is catching up in developing countries also. The rise in maternal mortality has been attributed to growing number of women with congenital heart disease surviving to childbearing age and the presence of comorbid pre-existing conditions like anemia in India. Cardio-obstetrics has emerged as an important multidisciplinary field which consists of obstetrician, cardiologist, anesthesiologist, neonatologist requiring a team approach in managing cardiovascular disease during pregnancy, right from preconception to antepartum, peripartum, and postpartum timeframes, which is essential to improve the cardiovascular outcome to reduce the maternal mortality. We are very grateful to our cardiology and anesthesiology colleagues who have been helping us managing these complex cardiac problems successfully to be able to give a better outcome for mother and fetus both. We at Unit 2 present this grand round 3 years data from August 2021 to 24 of successfully managing the complex cardiac problems in pregnancy at AIIMS New Delhi. I'll request Dr. Rajesh, who is additional professor. She will introduce the subject. Dr. Sakshi JR, who will present the data. Dr. Jayashree, our senior resident, is going to review the literature. And Dr. Neha, associate professor, she's going to summarize. So to start, Dr. Rajesh, please.
Thank you, ma'am. Good afternoon, respected seniors and my colleagues. So today we will discuss heart disease in pregnancy. What are different heart diseases and how to manage these patients pre-conceptional, during conception or during pregnancy. What are the signs, symptoms, and what is the need of surgery and uses of anticoagulant drugs. So our title is Balancing Two Beats in Single Journey, Heart Disease in Pregnancy. So heart disease, according to literature published, heart disease in pregnancy affects 0.2 to 4% all pregnancies, and rheumatic heart disease is common. We all know this thing. And mortality rate is 1.9% women with MS during pregnancy. And 15% of patients with severe MS develop heart failure in during pregnancy because physiological changes of pregnancy in the body. So MS leads to the adverse fetal outcomes also, like preterm delivery, IUGR, and low birth weight, and neonatal death due to other complications. And 20% of pregnancies in the presence of valvular involved with the each patient teaching us a different aspect of the same disease. So now we will discuss about our experience of heart disease with pregnancy of last 3-year data. And now I invite Dr. Sakshi to discuss our data from the department.
Good afternoon, seniors and my dear colleagues. So today I will be sharing our experience with the heart disease patients in pregnancy. So from 2021 to 2024, we had 74 rheumatic heart disease patients, and in which interventions done prior to or during pregnancy, the number was 31. And out of that, interventions done during pregnancy was 5. The cardiac interventions done, the first one PTMC 45.1%, followed by NPR 35.4%, followed by DVR 16.1%, and followed by AVR. So we'll be discussing between two groups. We have one first group is intervention done before pregnancy. The number is 26. And the second group is the patients who did not require any intervention. The number is 43. So age at presentation. The maximum patients we had were of the age group 26 to 30. In the first group, it was 50%, and in the second group, it was 41.8%. The maximum patients got diagnosed with rheumatic heart disease before the age of 15 years. In the first group, it was 69.2%, and the second group, it was 58.1%. Our maximum number of patients were booked. And in the first group, the maximum patients were multigravida, that is 57%, and in the second group, our maximum patients were primigravida. So the affected valve, most of the patients had single affected valve. In In the first group, it was 88.4%, and second group also 88.3%. And the severity of mitral stenosis, most patients had mild mitral stenosis. That is in the first group 57%, and the second group 51.1%. Mitral regurgitation also, we had patients with the mild mitral regurgitation. And we had one patient with severe AIIMS, aortic stenosis. And her intervention was done before pregnancy, and this case will be discussed in detail further. And NYHA class, in the patients whose interventions were done before pregnancy, all the patients, maximum of them are in category NYHA class 1, that is 76.9%. And in the patients with no intervention done, 35% patients, 81% patients are in NYHA class 1. And WHO modified classification, our maximum patients from the first category belong to WHO 2 to 3 modified classification, and in the no intervention, 88.6% people belong to WHO modified 2 to 3. Antenatal complications, we had 3 GDM patients in the group with intervention before pregnancy, and 5 GDM patients in the group with no intervention. And severe IHCP, we had 2 patients in the no intervention group, followed by preeclampsia, thyrotoxicosis, and thrombocytopenia, 1 patient each in the group with no intervention. So maximum patients delivered at term, the rate being 84.6% in the group with intervention and 83.7% with the group with no intervention. And vaginal delivery was the more in 57.6% cases with the intervention group and 74.4% in the no intervention group, followed by cesarean section rate, which was 42% in the with intervention group and 25% in the no intervention group. And maximum neonates were appropriate for gestational age, 65% in the with intervention group and 88% in the no intervention group. And our 3 babies required liquid admission in view of premature delivery. Contraception, our maximum patients accepted Mirena LNG IUS well. In the with intervention group, 57% of our females accepted LNG IUS, and in the no intervention group, 41.8% accepted LNG IUS, followed by copper T and followed by female sterilization. So our current status of these patients, 25% of patients in whom the intervention has been done before pregnancy are stable and are currently following regular in the cardiology OPD, and 1 patient is still planned for repeat intervention. And in no intervention group, all patients are stable and under regular follow-up. So I hand it to Dr. Jayshree. Thank you.
Thank you, Dr. Shakti. Good evening, respected teachers and my dear colleagues. Now we'll be seeing the patients who underwent cardiac surgery intervention during pregnancy. There were a total of 5 patients in which cardiac surgeries were done during antenatal period, during pregnancy. These patients will discuss in detail. Most of the patients came with the complaints of worsening dyspnea with the NYHA class deterioration from class 2 to 4. 1 patient came with complaint of cough with sputum and hemoptysis already in class 4. And 1 patient came with complaints of palpitation and dizziness deteriorating NYHA from class 2 to class 4. These patients will discuss now. Total 5 cardiac interventions were done antenatally. 4 of them were PTMC. 3 were done almost to the POG of 20 to 21. 1 PTMC was done at period of gestation of 32 plus 1 week in 3rd trimester. Another 3 to AVR was done at immediate post-maternity 1. Coming to case 1, this is Mrs. B, 26 years old, housewife, resident of Uttar Pradesh, a booked patient at 15 weeks of POG. She was booked at AIIMS. She is gravida 2, para 1, previous no-living issue at 20 weeks POG with a known case of RHD with moderate MS, post-PTMC done 14 years back with history of CVA 4 years back. She was already on cardiac medications, tablet Dito 5 mg OD, tablet metoprolol 25 mg BD, and tablet warfarin 4 mg OD for CVA. She was started already in the pre-pregnancy period. Patient presented to our OPD with complaints of worsening dyspnea, and she was NYHA 4 at presentation. She was evaluated and echo was done, which was suggestive of severe mitral stenosis. Mitral valve area of 0.9 centimeters. She underwent PTMC at 20 weeks period of gestation and was continued on same medication, tablet Dito, tablet metoprolol, and post PTMC patient's NYHA improved from 4 NYHA 4 to NYHA 2 and post Post PTMC, her echo was suggestive of moderate MS and mitral valve area improved to 1.1 cm. At 36 weeks of POG, patient was admitted and her warfarin switchover was started and turned to injection flexing 60 milligrams subcutaneous bleed. Patient was induced at 38 weeks of POG with PGE2 dinoprostone gel. Epidural analgesia was offered to the patient and she delivered vaginally healthy 2.4 kg baby. Injection enoxaparin flexing 60 milligrams subcutaneously was started on post of day 1 and was switched over to warfarin 4 milligrams as in pre-conception period on day 5 postpartum, and she was discharged. She received contraception LNG. Patient is currently following up regularly in postpartum clinic and cardiology OPD and currently stable with anxiety class 2. Now coming to case 2, she's Mrs. S, 28 years old, housewife, resident of Delhi. She's a booked patient at 20 weeks of POG. She's a primary gravid at 20 weeks, known case of RHD, severe MS, mild TR, mild PAH, history of transient ischemic attack, post PTMC done 10 years back. She had complaints of exertional dyspnea from 20 weeks period of gestation, during which she was progressed from NYHA 2 to 4. She underwent echo and was diagnosed to have severe mitral stenosis with a mitral valve area of 0.8 centimeters square, with mild MR, mild TR, mild PH. She underwent PTMC at 26 weeks of POG in view of worsening NYHA class from 2 to 4. Post PTMC, she was started on tablet warfarin, tablet dito, and tablet metoprolol. Post PTMC, her echo was suggestive of moderate MS, and her improvement in her NYHA status was noted from 4 to 1. Patient was regularly following up in gynae ANC OPDs and detected to have stage 1 FGR on routine ultrasound growth scan. She was admitted at 36 weeks for heparin switchover, followed by induction of labor at 37 weeks in view of preeclampsia with uncontrolled BP records. Epidural analgesia was given to the patient and she delivered healthy vaginally a baby of 2 kg. She received a contraception of LNG IUCD. Currently, patient is stable with NYHA class 1 and following up regularly in PNC clinic and cardiology OPD. Coming to case 3, she's Mrs. R, 27 years old, resident of Uttar Pradesh, unbooked patient. She was already priorly booked at primary health center. She was gravida 4, para 2, living 1, previous 1 abortion at 32 plus 1 weeks POG with hypothyroidism with grade 2 hiatus. She was not a known case of cardiac disease already. Admitted in emergency with the complaints of cough and sputum and hemoptysis since last 2 months. She was corresponding to her POG. Patient had developed complaints of acute shortness of breath post admission. She developed pulmonary edema for which diuretics were given and was shifted to ICU. In ICU, bedside focus was done, which was suggestive of severe MS with a mitral valve area of 0.5 centimeters square, with low moderate MR and TR and severe PH. Patient was taken up for PTMC and post-procedure echo was suggestive of mitral valve area of 1 centimeter square with severe PH. Patient was stable during complete antenatal time and was followed up in antenatal clinic and cardiology OPD. Patient was taken up for elective LSDS at 37 weeks POG in view of severe PH and delivered a healthy baby of 2.5 kg. Postpartum course was uneventful. Patient was discharged on previous medications of Lasix and metoprolol. Currently, patient is stable and following up in PNC and cardiology. Coming to case 4, she's Mrs. D, 27 years old, nursing officer, a resident of Delhi. She was booked at GB Pant Hospital and then referred to AIIMS at 21 weeks of POG. Primary gravida, 21 weeks, known case of RHD, moderate MS, mild MR, trivial TR, already on tablet Lasix 10 mg body and metoprolol 25 mg BD. Patient was admitted with complaints of worsening dyspnea and orthopnea in NYHA class 4. Echo was done, which was suggestive of moderate MS with a mitral valve area of 1.2 centimeters square, mild MR and triple T. Patient was taken up for PTMC at 21 plus 5 weeks POG in view of worsening clinical condition, and the procedure of PTMC was uneventful. Currently, patient is antenatal 30 weeks POG, NYHA class 1 and following up in an ANC and cardiology. Coming to case 5, she's Mrs. R, 24 years old, housewife, a resident of Delhi, unbooked patient. She was initially booked at local nursing home. Primary at 28 plus 3 weeks POG with post-aortic valve repair done 10 years back on medications Ditor and enoxaparin. She came to emergency with complaint of palpitation and dizziness and in NYHA class 3. Echo was done, suggestive of prosthesis in situ with severe restenosis of aortic valve. She was admitted in labor room, kept on strict monitoring. On day 6 of admission at a POG of 29 plus 2 weeks, she started having headache, chest pain, and palpitation. Her heart rate was reaching up to 150 beats per minute. Her ECG was suggestive of ventricular tachycardia, for which a discussion with cardiology team was done, and she was given injection lignocaine followed by sodium bicarbonate and calcium gluconate for the treatment of ventricular tachycardia. And in view of maternal condition worsening, we started her on fetal neuroprotection with injection Maxel. Decision for emergency cesarean section was taken and redo AVR. Decision for emergency cesarean section and redo AVR was taken in view of deteriorating maternal condition. Then emergency cesarean section was done, and on post-op day 1 of emergency cesarean section, redo AVR was done. On the post-op day 0 of redo AVR, that is post-op day 2 of emergency section, in view of increasing drain output in pericardial drain and falling hemoglobin, she was again taken up for emergency thoracotomy and substernal bleeder was coagulated. Echo in post-op period was done, which was mild PR, rest valves were normal, post-op period was uneventful for this patient. Currently, this patient is stable and regularly following up in PNC clinic and cardiology. Now let's read about the guidelines. Coming to the rheumatic heart disease in pregnancy, RHD remains a major problem in developing countries like India. Prevalence of heart disease among pregnant women is 1.46%. Rheumatic heart disease being 70% and congenital heart disease being 18%. RHD is underlying cause of heart disease in nearly 56 to 92% pregnant women in Southeast Asian regions countries. The valves affected in rheumatic heart disease, most common affected valve, that is in half of the patient, is mitral valve, followed by mitral and aortic dual valve involvement in nearly 20% patients, and involvement of 3 valves, tricuspid valves associated with mitral and aortic valves is the third. Coming to mitral stenosis, normal mitral orifice area is 4 to 6 centimeters square. Most common cause of acquired heart disease during pregnancy is mitral stenosis. Predominantly, mitral stenosis is caused by rheumatic heart disease. Normally, with the mitral valve area of 2 to 2.5 centimeters square, the patient remains asymptomatic. Severe MS occurs with the valve area of less than 1 centimeter. Why this mitral stenosis is important in pregnancy? Now we'll discuss this. In nearly heart failure occurs in nearly 1/3 of the patients with valve area of less than equal to 1 centimeter square, and half of the patients with valve area less than equal to 1.5 centimeter square. Heart failure most often occurs during the second trimester, even in the absence of symptoms before pregnancy. There was a study done in 2023 by AIIMS et al. In the low middle income countries, which suggested that cause-specific maternal mortality ratio due to heart disease was 7.24 per lakh live births over a period of 12 years. Prematurity rates are also 20 to 30%, 5 to 20% rate of intrauterine fetal growth retardation, and fetal death is there in 1.1 to 5% cases. Now, how do we manage these cases in our antenatally? How do we manage these cases of heart disease? Normally, a multidisciplinary team involvement is a must thing, including obstetrician, cardiologist, anesthesiologist, and pediatrician. What are our concerns as obstetrician? Whether to continue this pregnancy or not, how to monitor this pregnancy, how to manage oral anticoagulants if the patient is having prosthetic valves in situ, when to intervene for cardiac surgery antenatally, and when to deliver this patient, and what should be the mode of delivery. Coming to the timing of surgical correction, normally, ideally, these patients should be optimized preconceptionally. Indications of preconceptional surgical correction are severe mitral stenosis. But considering India as the developing country, low middle income country, patients usually do not follow us in the preconception period. They come after getting pregnant or maybe in the antenatal period. So antenatally also, PTMC can be safely done after 20 weeks of POG, ideally 22 to 25 weeks POG. Indication of doing PTMC antenatally are severe symptomatic mitral stenosis or significant PH. Coming to the third trimester dilemma, if the patient has already reached third trimester, a patient of heart disease without any previous surgical cardiac intervention, then individualized decision has to be made after discussing with obstetrician, pediatrician, the patient itself, and cardiologist. After looking at the NYHA class of the patient and patient's current condition, there are 2 options at third trimester: whether to deliver the patient preterm and then followed by after the delivery of the patient, the cardiac surgery can be done, or cardiac surgery in the third trimester followed by delivery at term. Why cardiac intervention is, which cardiac intervention is safe? We'll discuss this. PTMC is preferred over the other surgical treatments, for severe MS in pregnancy because it has lower morbidity, shorter hospital stay, reduced cost, reduced morbidity, avoids thoracotomy, and it avoids thoracotomy and prolonged general anesthesia. Why cardiac surgery is important for severe MS even in pregnancy? Because mortality risk is 12 to 31% in women with class NYHA class 3 and 4. And prematurity rates are also high, that is 20 to 30%. IUGR rates are 5 to 20%, and stillbirth rate is 1 to 3% in patients with severe MS. Now coming to the basic thing we do in our antenatal patients for the anticoagulant thing. Anticoagulants are indicated for the mechanical valves, not for the bioprosthetic valves. We usually admit these patients at 6 weeks or after fetal cardiac activity documentation, and then we switch these patients from warfarin to heparin, and we'll continue the heparin till 12 weeks of POG. We'll titrate this. We can either start unfractionated heparin or low molecular weight heparin. Unfractionated heparin is titrated using APTT, which should be twice the normal range, which is 60 to 90 seconds. And low molecular weight heparin is titrated with factor anti-XA levels. From 12 to 36 weeks, patient will again start on her warfarin dose. INR should be maintained between 2.5 to 3.5. At 36 weeks, we'll again admit the patient and stop the warfarin dose and start heparin till labor. We'll restart after 6 hours of, we'll restart the heparin after 6 hours of normal delivery and 24 hours of cesarean section, depending on the risk of hemorrhage. We'll discontinue heparin after overlapping with warfarin once the target INR is achieved. Coming to these two guidelines by European Society of Cardiology given in 2018, that women with mechanical valves, there are controversial points based on these guidelines. That these guidelines suggest that if the patient is already taking vitamin K antagonist, that is warfarin, less than 5 milligram per day if she is taking, we can very well continue the same dose during pregnancy. But if the patient is taking more than 5 milligram per day, then at first trimester during the period of embryogenesis, we need to discontinue warfarin and we should start her on unfractionated heparin or low molecular weight heparin. Coming to mode of delivery, in heart disease, vaginal delivery is preferred mode of delivery because it is associated with less blood loss, lower risk of infection, lower risk of venous thrombosis and embolism. Cesarean section is to be done if obstetrical indication is there, any decompensated cardiac failure, a patient who is anticoagulated already in labor on warfarin, and severe PAH. Now, when should we deliver these patients of heart disease? Normally, spontaneous onset of labor should be preferred, but if the patient does not go in spontaneous labor till 40 weeks of POG, then elective induction of labor can be done. This reduces the risk of emergency cesarean section by 12% and risk of stillbirth by 50%. Coming to the general considerations which we do during labor room, we should reduce the effect of tachycardia and increase cardiac output in labor in these patients. So, a pain relief is given to reduce tachycardia and cardiac output load. For pain relief, we'll provide them effective analgesia, epidural analgesia we provide them, and a restriction of IV fluid should be done at 75 ml per hour. Patient vital should be seen and oxygen inhalation and pulse oximetry should be there at bedside. Anticoagulation if needed in cases of mechanical valves will start. Antibiotic prophylaxis should be given in these patients. We should cut short the second stage of labor using instrumental delivery. Fetal heart rate monitoring should be done during second stage of labor also. Management of PPH should be done, but we should avoid IV methergine and bolus oxytocin to control PPH. Coming to the contraception in heart disease, LNG IUCD is MSC1 in contraception in heart disease, and followed by copper T, followed by progesterone only pills, centromin and implanon are considered safe. Coming to the review of literature, there was a study done in 2015, a case series of 2 patients by Kapoor et al. There was intervention of cardiac intervention done PTMC antenatally in these 2 patients. First patient they did PTMC in 27 weeks, and second one they did at 33 weeks. Both patients, no maternal complication, no fetal complications were there with no adverse event. Patient delivered at 38 weeks with spontaneous labor, and the second one was induced at 39 weeks and delivered healthy babies. Coming to the second study, it was a retrospective study done in 2022 in the northern India by Vijay Varghese et al. There were total 70 patients in 10 years. PTMC was done. Mean POG at the time of intervention, cardiac intervention, was 29 weeks POG. The mean POG at delivery was 37 weeks. Most of the patients delivered vaginally, which was 79.6% patients, and 18% patients had cesarean section. There were few maternal complications noted in these patients. That is, 13 patients had anemia, 3 had gestational hypertension, 2 developed preeclampsia. 1 patient had post-PTMC severe MR. In fetal complication, abortion, 1 patient had abortion after PTMC. 3 patients had stillbirth, and there was 44 growth-restricted babies. There were 2 unsuccessful cardiac intervention also, 1 with severe MR and 1 with failed balloon. The third study, done in 2023 over a period of 5 months, it was a descriptive cross-sectional study by Koirala P. et al. There were total 31 patients in which PTMC as a cardiac intervention was done, and maximum patients, that is 45% patients delivered vaginally, and 38% patients had cesarean section. Maternal complications also, there were 13 patients who had preterm labor, 5 patients had preeclampsia, 6 patients had anemia, 2 had abruption after this procedure. Fetal complications of low birth weight were there in 12 babies. 1 baby was stillborn and neonatal death was there in 4. Coming to the same study, we continue. This study also compared two groups. That the first group was mitral stenosis with PTMC done during pregnancy. With number of 8 patients were taken in this group, and the mitral stenosis without PTMC during pregnancy, a total of 23 patients were there in this group. And they compared these two groups and found out that in the second group 2, mitral stenosis without PTMC during pregnancy, they were higher risk of cardiac failure, atrial fibrillation, CCU, ICU admission, and maternal mortality. This was a study done in 2018 at AIIMS, also AIIMS Obstetrics department only. It was a comparative study on maternal and fetal outcome in pregnant women with rheumatic heart disease and severe mitral stenosis undergoing percutaneous balloon mitral valvotomy before and during pregnancy. They compared these two groups. Group 1 was valvotomy done before pregnancy, including 10 patients. Group 2 was valvotomy done after pregnancy, including 10 patients. The mean gestational age was 38 weeks in the first group and 39 weeks in the second group. Most of the patients had vaginal delivery in both groups only. The mean birth weight was 2.3 kg in the first group and 2.6 kg in the second group. Risk of FGR was high in the group 2, in which valvotomy was done during pregnancy. The risk of stillbirth was higher in the group 1, in which PBMB was done before pregnancy. So to conclude, in a patient with pregnancy and severe mitral stenosis, PBMB performed either before getting pregnant or at the time of pregnancy leads to equivalent maternal and fetal outcomes. Over to Dr. Neha.
Thank you, Jayashree. Now I'd like to invite Professor Sir to give his comments in managing such patients.
Yeah, I think it's a wonderful presentation. But 2 things I just want to highlight. If a patient of mitral stenosis came on after first trimester with class 3 symptoms, don't wait. But these patients will, whether the wall area come to 1.1, 1.2, 1.9, it doesn't matter. Most important is the symptom. So if you send for echo will write 1.2, then we can carry on the pregnancy risk. Symptoms are more important. So if after first trimester a patient is class 3 symptomatic, obviously this patient requires intervention. That is the first thing. Second important thing, this is a common tendency outside to do cesarean for all these patients. Absolutely no. We always say vaginal delivery is more, and in our series I think we are more preferring the vaginal delivery. Third thing, what I have seen, that changing from VARF to heparin, that created more complications, especially in prostatic than continuing warfarin. We have an apprehension that more than 6 mg have a very high chance of some congenital anomaly. It is not based on any data. And when you are switching over from warfarin, especially in prostatic valve, what is happening? You are giving 5,000 low molecular unfractionated heparin BD, and we never measure APTT, and we cannot measure because it's a costly affair, and the results are not, I can say, equal in all the labs. So in my view, if patient is on 5, 6, 7 milligram is maintaining, I don't think that we should switch over so frequently. Though it is written in all guidelines made where there's a lot of other things is going on. In this problem is basically a low socioeconomical problem. So in my belief, we continue it, and majority of the time we get a patient when patient is already 6 weeks pregnant. So unnecessary changing at that time is not going to solve. Second important thing, during delivery, you always switch over at 36 weeks, 14 days prior. I don't think if you anticipate that she is going to deliver, you can very well switch over 5 days. So it's not mandatory to admit all patients at 36 weeks, base your bed for 2 or 3 weeks and switch over heparin, because warfarin effect will go within 3 or 4 days. So you don't require 15 days to overcome the effect of warfarin. And the second important thing, what I have seen that majority of the patient with moderate MS, we restrict fluid. You say plenty of fluid. So there should be a balance. They should not take unnecessary huge amount of fluid because you are giving them a diuretic. And you are, I think you are afraid of that amniotic fluid will be less. So you advise drink 3 liters of water. We give diuretics and say, no, please don't give 3 liters, give 1 liter of water. So let us compromise in this. Don't advise more than 1.5 liter of water. I always say just take 1.5 liter of liquid intake. If you take 1.5 liter, I think there will be around 2.5 liter liquid to be taken and it is sufficient. So we have to decrease the dose of diuretics. If you give more fluid, we have to increase the dose of. So often I see we say restrict your fluid, they go to gynecology OPD and start here say eat 3 liters of fluid because there is a suspicion that you will have a decreased amniotic fluid level because of diabetes. So these things, and third is a beta blocker. In these patients, I always request you, there's wall area is 1.5. If the heart rate is more than 100, they will definitely be symptomatic. So keep their heart rate around 65. So don't hesitate to increase the dose of beta blocker. Especially in these situations, they are more sympathetic drug. So calcium channel blocker is not going to help more. So if you increase calcium channel blocker, they all are immune sympathetic drug. So keep beta blocker. So beta blocker, I think the beta blocker, which is I prefer to give always in the retinol in these patients with metabolite. So there is no study, but I think the retinol will be less transferred to the fetus circulation as compared to metabolite. So always if the patient comes, always increase the dose of beta blocker. Don't send to cardiac OPD for increasing dose of beta blocker. If you find the heart rate is more than 75, you yourself increase the dose. Restrict the fluid. The diuretic should be as minimal as possible. Every drug in pregnancy should be as minimal as possible. But increase beta blocker from your side. It doesn't matter if they are on 50 milligram retinol, 75, but control their heart rate to 65 to 70. I think. So my message, and I think this is the only institute which is taking care of these type of patients. And second important thing, doing PTMC, if it is done with a very good hand, there is absolutely no problem. I, in my whole life, have not found any significant complication doing PTMC. And I prefer to do at 24 weeks. That is the ideal things which should be done 24 weeks. If valve area is 1.5, 1.4 patients start having symptoms, just do a PTMC. Third thing, especially in our setup, there is a tendency to dilate less. The patient will have a severe. It is also not wise to dilate less. The recommended diameter should be reached in these patients because chances of MR doesn't increase by dilating the wall appropriately. And the third important thing which I always say, surgery is always risky. And important thing with the message I want to give, if you have a severe AS and patient is asymptomatic till 30 weeks of pregnancy, she can very well have a normal delivery. She may be symptomatic, take them to take rest. Don't try to intervene in 34 weeks, 36 weeks. You should increase the medication, advise them, and majority of the time if you see the patient who are at 36 weeks class 3 and they are taking at least 4 liters of water per day. क्योंकि घर में भी टेंडेंसी होती है कि पानी खूब पियो प्रेगनेंसी में और वॉल डिजीज है तो जस्ट आस्क 3 क्वेश्चंस व्हाट अमाउंट ऑफ ओरल फ्लूइड यू आर टेकिंग restrict them to 1.5 liter increase your beta blocker हमारे में उसको 1 महीना लगता है अपॉइंटमेंट लेने में so that we have seen it you don't want to increase beta blocker why you are afraid of increasing beta you increase yourself bring the heart rate to 65 decrease their fluid intake and if they have passed 30 weeks 99% will have a normal delivery. So this is my message to you. Thank you very well. And very well done. Thank you.
Thank you, sir. Thank you for giving us your expert comments. Now I request Dr. Nirmal to give his comments.
Good afternoon, everyone. Very nicely presented and comprehensively reviewed presentation. I think sir has already discussed each and every topic, important topic, how to manage these IGT patients who are pregnant. I just want to tell you that not all patients with severe AIIMS requires intervention. First of all, medical therapy, that is diuretics, beta blocker, heart rate control, that should be properly managed. And even after that, if the patient is symptomatic, they need PTMC or intervention. And surgery is not a good idea because during the bypass, there is a very high risk of fetal loss and other complications. So that's all. Thank you.
Thank you, Dr. Nirmal. Now I request Dr. Anil from anesthesia to give the anesthesia concerns in these patients.
Very good evening, respected seniors and dear colleagues. First of all, I would like to thank Neena ma'am and the Gynae department for giving me this opportunity to present my perspective. So, it is a widespread consensus that best obstetric and neonatal outcomes can be achieved by a combined multidisciplinary coordinated approach. And we all are familiar that rheumatic heart disease is the commonest cause of acquired heart disease. So pre-pregnancy, if the patient presents to us, the therapy for severe MS and moderate MS, which is symptomatic with decreased exercise tolerance, is percutaneous balloon mitral valvotomy. And in rest of the patient can be managed with medical therapy. During pregnancy, if the patient presents with severe MS and despite maximal medical therapy, if the patient is symptomatic and exercise tolerance is reduced, then we can go for percutaneous balloon mitral valvotomy, and the time window is the second trimester. So hemodynamic changes during pregnancy, we all must be aware of this. The cardiac output increases, the blood volume increases, systemic vascular resistance decreases, and during labor, all the changes are magnified. There is an increased cardiac output up to 80% postpartum, auto transfusion of blood. So all these, exaggerates the cardiac hemodynamic changes. Now, why is MS poorly tolerated during pregnancy? Because during pregnancy, all the changes, all the pathophysiology of the mitral stenosis, it is magnified and it is exacerbated due to the pregnancy-related physiological changes. So there is in mitral stenosis, there is a fixed cardiac output, and pregnancy-related increase in blood volume leads to an increase in transvalvular gradients. And there is an increase in incidence of pulmonary edema. There is an increase in incidence of right ventricular heart failure and poor tolerance of tachycardia and increase in cardiac output. And these all changes do occur in pregnancy. So these changes are important to know to understand the anesthetic implications. So pathophysiology related to mitral stenosis is mainly related to the increased rise in the left atrial pressures and gradual left atrial dilatation. So increasing left atrial pressure, it leads to increased pulmonary venous hypertension, which in turn leads to slowly over a period of time to pulmonary arterial hypertension, which in turn leads to right ventricular heart failure, and then left atrial dilatation, it leads to atrial fibrillation and stasis of blood. And if there is a chronic stasis of blood, it leads to thrombosis formation and systemic embolization. So hemodynamic targets for these patients who present for labor analgesia are to control tachycardia and maintain a heart rate of less than 90 at all costs. We should have a low threshold for invasive monitoring, which will help us in guiding the fluid therapy and our analgesia. And we should go for a titrated incremental regional anesthesia, that is epidural anesthesia or combined spinal epidural anesthesia. And for first stage, even opioid-based analgesia is recommended. Now, what we don't have to do is we do not have to precipitate tachycardia. The maternal expulsive efforts, all this will lead to increasing tachycardia and maternal decompensation. Large fluid boluses should be avoided, and preloading should be avoided. Ephedrine should be avoided as a vasopressor. Single shot spinal should be avoided, which can lead to massive vasodilatation, and large volume should be avoided. So labor analgesia during the second and the third stage, what is the recommended strategy? We should go for small fluid aliquots for maintaining the hydration. Poor hydration is also not recommended, but definitely overhydration is not recommended. We should maintain adequate segmental and perineal analgesia. Good perineal analgesia will avoid the urge to push and will control the tachycardia. We should avoid oxytocin use, which will also, especially we should avoid the boluses, which will lead to tachycardia. Lithotomy position should be avoided as much as possible, especially in severe MS. Patient should be maintained in severe propped up position with the oxygen by nasal prongs or mask. And we should try to shorten the second stage by use of forceps. And we should observe these patients at least for 24 hours. So CSE, combined spinal epidural analgesia in laboring patient, it is associated with during the second stage epidural analgesia. It facilitates an increase in venous capacitance. This increase in venous capacitance is important to accommodate the acute rise in venous return and cardiac output, which happens during the immediate postpartum period. So it is very important. And in first stage, we can go only for intrathecal opioid. We should avoid intrathecal local anesthetic, and intrathecal opioid will provide immediate and excellent analgesia without any sympathetic blockade. So what are the anesthetic concerns if the patient present for LSCS? Now we have to control the heart rate to a lower end of the normal, that is less than 90. We should avoid any tachycardia. We should preserve sinus rhythm. It is very important to maintain sinus rhythm. It is very important to restore or maintain intravascular volume. We have to avoid any marked increase in the central blood volume, and we should prevent any systemic vasodilatation like during spinal anesthesia. We should avoid any pulmonary vascular increase in pulmonary vascular resistance. These are the factors which increase the pulmonary vascular resistance, that is the hypothermia, hypercarbia, hypoxia, and acidosis. So monitoring, all routine monitoring are obviously used during cesarean section. For mild and minor surgeries, we can go for non-invasive monitors. But for patients who have severe disease and surgery with huge fluid shifts, like cesarean, even for cesarean section, we will go for low invasive monitoring at a lower threshold. Arterial line, pulmonary artery catheter, even TE is used in advanced setups. So regional anesthesia has some advantages in this setup. Fixed cardiac output may result, it has some advantages, some disadvantages. So spinal anesthesia, we have to be cautious that this is a fixed cardiac output state. The cardiac output cannot be increased. So any reduction in the systemic vascular resistance will lead to profound hypotension, which will not be able to control. Then epidural analgesia has a edge over spinal analgesia because it leads to a gradual fall in the systemic vascular resistance and blood pressure. So we have a time to control the hypotension. And combined spinal epidural provides the initial dense analgesia, and also we can control and we can extend the analgesia in the postoperative period. So combined spinal epidural is generally preferred from our side. It has a rapid onset, it provides improved analgesia. We can use low-dose spinal, so which will reduce the reduction in the systemic vascular resistance, and we obviously can extend the analgesia into the postoperative phase. So now for general anesthesia, there are some drugs which are to be avoided, like ketamine, which precipitates tachycardia. Etomidate, it preserves the cardiac contractility, that is preferred. Fentanyl, morphine induction is preferred, and nitrous oxide is generally avoided because it leads to pulmonary hypertension. All inhalational agent will lead to hypotension. It will lead to decrease in blood pressure. So we have to use judiciously. Enflurane, halothane, they are not even used now. Desflurane is sometimes used, but it can lead to tachycardia. And isoflurane and sevoflurane are relatively safe, and they lead to, the problem is they do lead to decrease in systemic vascular resistance. So all this anesthetic agent can be detrimental. We have to, titrate, and we have to customize our anesthetic management. So phenylephrine, rather than other drugs, ephedrine should not be given. Phenylephrine is preferred because the reflex decrease in heart rate will be beneficial, and it will not lead to tachycardia. For reversal, glycopyrrolate is preferred, and Bithargine is contraindicated for uterotonic purpose. Oxytocin, the boluses should be avoided, and only infusion should be used. Now coming to the post-operative care, these patients, especially with severe disease who are symptomatic preoperatively, they should be continued for monitoring in the ICU setup, and adequate and very good, excellent post-operative pain relief is a must, and cardiac medication should be restarted orally. So to summarize, the unique physiological changes which are associated with pregnancy itself, they lead to exacerbation of the pathological impact of the mitral stenosis. It is very important that we understand the pathophysiology of the lesion to optimize our anesthesia technique and to optimize the patient outcome. And multidisciplinary approach in the diagnosis and management always leads to improvement in the mortality and morbidity. The choice between regional and general anesthesia is a relative one. It may not, it is not absolute. It is not that one technique definitely improves the morbidity and mortality. The more important is the meticulous monitoring, hemodynamic monitoring, and providing a good post-operative analgesia. Thank you very much for your patience.
Thank you, Dr. Anju. Finally, to conclude, prevalence of heart disease among pregnant women is 1.46%. Rheumatic valve disease is the most common, almost 64% cardiac diseases in pregnant women. Mitral valve is the most common valve involved in rheumatic heart disease during pregnancy. Patients should be ideally optimized in the preconceptional period. PTMC can be safely done after 20 weeks, preferably between 22 to 25 weeks of period of gestation. Vaginal delivery is the preferred mode of delivery. Spontaneous onset of labor is always preferred. If doesn't goes into spontaneous, then elective induction can done at 40 weeks of period of gestation. PTMC done during second trimester is associated with successful perinatal outcomes. We express our heartfelt gratitude towards the head of the department, Obs and Gynae, faculty and other faculty and residents of the Department of Cardiology, Anesthesia, CTVS team, Pediatrics, our nursing officers and other supporting staff, social workers, and all our patients. Thank you. Now I invite Neeta Singh ma'am to conclude.
I think it has been very well presented and highlighted, and Dr. Rakesh has very well given us some very good take-home messages. Regarding the warfarin, what he has said, we'll have to change the department policy, I think, if we want to continue with the oral anticoagulant. I think last time we had a cardio-obstetric workshop, somebody coming from UK and some, I don't remember the name, some South Indian who's doing a large survey on some heart. Yes. The cardiac disease in pregnancy. He also reiterated that in low resource setting, it is better to continue on warfarin rather than shifting because it is not advisable. Not many people are here to understand how much should be PTM, APTT and INR should be kept, and then these patients are badly controlled. So bad controlled anticoagulants is worse than giving these switchovers, and warfarin is the drug of choice. He said giving up to 5 milligram does not increase risk of any kind of nasal bone hyperplasia or any major malformations. Second point which he highlighted regarding controlling the heart rate, and he rightly said that sometimes we keep sending references, patients shuttling between obs and cardiology just to increase the dose of metoprolol or atenolol. So we can very well titrate ourselves, and if there is any problem, we can on phone, we can talk to them. So this is a very, very important take-home message for all of us, that we keep the heart rate as he suggested below 70. Is that all right, Dr. Rakesh? Below 70 is what he mentioned. Third, very important point, he rightly said that we do not normally mention the patient how much fluid the patient is taking. We have to restrict fluid, and sometimes we feel that the patient is on diuretic and we do not want to restrict fluid. As he said that fluid restriction is the cornerstone of management in decompensated heart disease who are on diuretics. If we keep it like 1.5 liter, we all should see that how much fluid the patient is taking. We'll be able to manage the severity of the heart disease. And fourth, I would like to, Neha has already acknowledged that you have seen in the series of patients which we have managed in 3 years, we had zero mortality and zero morbidity. That calls for, there's been a very, very good support from the ancillary departments like cardiology, anesthesiology, and the neonatologists, and we should acknowledge their efforts that with their continued support, we were able to optimize the outcome in these very complex cardiac problems at AIIMS, which are referred to as sometimes odd hours when we have to handle, and we look forward to continued support in future as well. And to end this here, I would request Dr. Neena if she wants to add something. Dr. Neena, please.
While it's certainly been a very comprehensive CGR, and I would just say, I think heart disease continues still to be a nightmare for all of us. I'm sure for the cardiologists when we send them, I don't think it's a nice kind of news we send. Waterloo, of course, and I think we've had repeated, CGR over this topic. I think last year we also, this year only we presented. Just one question, Rakesh, is out of interest. We say we're a developing country, we're seeing, we've not seen any decrease in rheumatic heart disease as you would get, like what I saw the PTMC being done. We are still on same numbers. For our men, do you think you do get a sizable proportion, or you see that there's, because obviously pregnancy is not the issue, but generally, male to female, is there any changing trends between Indian population, the diaspora as we look at, because we've not seen any changes.
The number of domestic heart disease, though it has been suggested that it is decreasing overall because the population is increasing, the rural part is increasing. Heart disease has decreased slightly, but not so. And the second important is still awareness. The patient is having severe microcytosis. They know that they are having severe microcytosis. They know they are having primary pulmonary hypertension. Still they get. That social message is very difficult. When they become distant, they come. We advise that get to pregnancy, that before pregnancy, don't get pregnant when you are a primary pulmonary hypertension, you are larger number. You explain them, there's 30% mortality, they will also. So this will never decrease. I can.
That's what I want to get this.
So you have to do all your care with these guiders. They will still see your hair. They will still have a pregnancy. So you cannot help it out. We have to not solve this problem. We have to treat them.
Because because I think they listen to you more, because by the time they come to them, actually primarily your patients, and I think the faith that you all build, but surprisingly most of them that we get for an emergency, I keep getting perplexed, and then they'll come back to you in the second pregnancy as well. So I think we can't deny that being a tertiary referral center with so many comprehensive things in the ambit of availability, we still will keep getting, and I think it's a way to sort of train our generations to come, unlike most Southeast Asian countries like Malaysia and Singapore, who probably postgraduate don't get to see. Still dramatic, we will still get to see them. So thank you very much.
Thank you all for joining us. Thank you, Rakesh sir, Dr. Nirmal, Dr. Anju for joining us. Thank you.